Good afternoon, respected chairperson and dear colleagues. Thank you, Dr. Sambaram, for making the topic easy. So my job is how to do dual femoral plating and what and how we should do a dual femoral plating in primarily. Everybody knows that in non-union we have to go for a absolute and rigid stability. So that's why we use a non-union double plate. But why not to use primarily double plate? So this was the case, 62 years old, polytrauma with grade 3A compound. If this patient comes to you in your casualty, and you can see that there is a Hoffa's element as well. So if you see Hoffa's, comminuted fracture, compound fracture, and if you see CT scan very closely, so how will you get a stability with the single lateral plate or even with the nail? So it is C3 type of fracture, which I will go ahead and I will use this dual plating approach, and this is how I did, and this is how the medial plate, you can see a lateral femoral plate. This is from the Bone Tech company, and this is the lateral plate, and you can see a primarily good end result of the primary dual plate. So distal femur fractures are complicated fractures. Despite recent advances, there is still challenge present because they don't give you a good result. Comminution, poor bone stock is a challenge. Adequate and stable fixation may not be possible in each and every case, even if there is a low supracondylar fracture. And that is why this is a paper which states the primary indications of primary double plating of supracondylar and intercondylar femoral fracture. So as you know, this is the AO classification, and where we have a problem between in the C2 and C3 fracture where medial side is not stably fixed. So rest of the classifications are easy to know how to do it. So we know what are the modalities. There are different type of modalities available. Distal femoral plate, condylar blade plate, then a nail with side plate, external fixation, and we use dual plating. So what are the problems? Insufficient distal fragment is the first problem. Inadequate medial buttress or inadequate contact, comminuted fractures, compound fractures, and vascular compromise. These are the indications where we need to know when we want to have a good stable fixation. So we should also know that these are the deforming forces. Quadriceps causes shortening, adductors causes varus, and gastrocnemius causes recurvatum. So this is a basic what we have learned during residency, but still we have to fight it against this and then get it correct and then stably fixed. So what are the indications of primary double fixations? These are medial gap more than 2 centimeters, intercondylar comminuted fractures, low transverse bicondylar fractures, displaced medial condyle Hoffa's fracture, periprosthetic fractures, non-union fractures, and elderly osteoporotic fractures with poor bone quality. So timing, you can do primary dual plating, you can do second stage, means stage 1 lateral, stage 2 elective medial plate, and third is non-union of distal femur, when you have to revise everything when there is a non-union with 2 plates. So this is the first case where you can see this is the compound femur, distal femur, C3 type of fracture. Initially it was bad, so we debrided, but on the day 1, in the same night, we have done this interfragmentary screw fixation. Then after 1 week, we electively went inside after the first debridement and decided to go for a bicondylar plating. So this is how this patient was fixed. You can see that the 2 plates, and which was with 2 incisions medially and laterally. This is 1 month follow-up, 2 month and 3 months follow-up, 6 months follow-up showing good union. The good callus is formed. This is 1 year follow-up, and this is the patient at the end of 1 year having range of motion up to 90 degrees and 0 to 19 walking normally. So at such type of comminuted compound fracture, even if you get 0 to 90 and patient is walking well and good union, you are achieved a good result. Another patient, 30 years old male, grade 3A distal femur fracture, and this was fixed with dual plate primarily, and because you are doing it for the immediately after the injury, so within 1 day. So this is fixed. This is 6 months follow-up, dual plate 2 years and 3 years follow-up, and patient had a good end result even after compound fracture primarily fixed. This is 30 years old male, motorcycle accident, grade 3C fracture, shifted on NORAD drip because it was a vascular injury. After exploring, we found that there was a femoral vein rupture along with compound fracture, so he was continuously oozing. So he was taken in for a vascular repair, and vessel was intact, artery was intact, so vein was repaired. And same time before repair, we have fixed this primarily, waited with the limb survived. 3 months follow-up, electively decided now it's time for going for the second stage surgery. This is a second stage plate which was used, and bone grafting was done. A medial plate was added. This is a follow-up X-ray, and this is united. Another patient with 31 years old, motorcycle accident, polytrauma patient, being fixation. Again, we have decided the patient's condition, the lateral side, the only lateral condyle fixation was done depending on the soft tissue conditions. And then electively after second stage, second month, we have done a medial plating and bone grafting of this patient, and in the end we had a good end result and good union. This is 1 year follow-up of the same patient. He had a nephrotic syndrome, so he had a delayed union. Coming to the non-union scenario, our friend Devendra is here. His institute paper, the algorithm for non-union by Raja Bhaskar and Dinu and Dr. Devendra. There they have decided how to go about a non-union algorithm. He will speak, I think, in the next lecture. So depending on the bone stock and insufficient bone stock, whether it is stable or whether it is poorly fixed, refixation, and most important, medial void, no void, only bone grafting, less than 2 centimeter, structural support and bone grafting, and more than 2 centimeters, add medial plating and bone grafting. That is why Ganga Hospital advised with this their landmark paper. Another patient of non-union, this is the patient known to me, but she got operated elsewhere, fixed with lateral side, open reduction, this bent and failed, came back for the double plating, used bone graft, transverse, as well as used DBM and bone graft. And finally patient united, 6 months follow-up. This is 18 months follow-up, completely healed patient. So complications are there. Infections, distal femur non-union, smokers are important, and knee stiffness. You have to tell your all patients that, look, distal femur fractures are not without any complications. You have to adequately counsel the patient that you will not get full knee range of motion. Otherwise, they will keep complaining कि इतना अच्छा हुआ लेकिन घुटना तो नहीं bend हो रहा है. So take home message is, I always say that double plating decreases lever arm which acts on the femoral axis, thereby decrease in load on the fracture side. You always compare distal femur as supracondylar fracture of the elbow. Will you use only one lateral plate? No, because medial side will be unstable. Similarly, in such low fractures, comminuted fractures, if medial side is kept weak, then you will not get good end results. So compare this with TY elbow and you will get the good end result. Thank you.